Good morning, everyone. Welcome to the breakfast talk. My name is Dr. Ng Wei Lin, an intervention radiologist from UMMC. This morning, we'll be welcoming Dr. Prasath, who'll be talking about tackling the thyroid lesions with the TI-RADS score. Dr. Prasath is a new addition to the biomedical imaging family of University Malaya. He just completed his gazettement and training in Sabah after his master's program. He was also one of the top presenters for the 2021 Asian Oceanic Congress of Radiology oral paper presentation. Currently, his interest is in intervention radiology and in nuclear medicine. Let's welcome Dr. Prasath.
Hello and good morning. I'm Prasath from the Department of Biomedical Imaging. Thank you for joining us today. The aim for my talk is to give insight on the ACR TI-RADS system of assessment of thyroid nodules, as well as the criteria which guides our decision whether to follow up or fine needle aspirate lesions. I hope it will be beneficial to our clinical and radiology colleagues alike. Without further ado, let's start tackling thyroid lesions with TI-RADS. Thyroid nodules are extremely common in the population and the risk of malignancy is relatively low. By virtue of the sheer prevalence, this leads to intervention of many ultimately benign lesions. Ultrasound is superior to other modalities in characterizing thyroid nodules. Before the use of ACR TI-RADS, many sonographic reports were non-specific with inconsistently applied descriptors used, thus resulting in the necessity for fine needle aspiration or even surgery for diagnosis. A reliable, non-invasive method to identify which nodules warranted FNA based on the likelihood of malignancy was needed. What is ACR TI-RADS? The ACR Thyroid Imaging Reporting and Data System, TI-RADS, was published in 2017. It is a reporting system for thyroid nodules on ultrasound proposed by the American College of Radiology. The goals were to develop management guidelines for nodules that are discovered incidentally on CT, MRI, PET, or ultrasound, to produce a lexicon to describe all thyroid nodules on sonography, to develop a standardized TI-RADS risk stratification system based on the lexicon to inform practitioners about which nodules warrant biopsy. This system is not the only thyroid assessment protocol, although it is the most widely used. ACR TI-RADS has good sensitivity and specificity, good inter-observer agreement, and good performance, resulting in lower rates of unnecessary fine needle aspiration. This is a yet unpublished retrospective study done in our department, which looked at 109 nodules with good diagnostic quality ultrasound images and the FNA results. Out of these, almost half would not have been warranted for fine needle aspiration based on the ACR TI-RADS criteria. I'd like to point out that 3 out of the 51 nodules that were not warranted for FNA turned out to be malignant. That being said, they would still have been captured for follow-up under the TI-RADS system. These are some of the more important features that are associated with thyroid cancer: macrocalcifications, hypoechogenicity, irregular margins, solid appearance, vascularity, and taller than wider appearance. Hypoechogenicity is of particularly high sensitivity, whereas almost all of these features are quite specific and offer good negative predictive value. This is the TI-RADS assessment chart showing 5 categories on the basis of the TI-RADS lexicon. Each category has descriptors of nodules that carry different weightage by points. I would like to mention that for composition, echogenicity, shape, and margin, we only choose one criterion each. If a nodule has different features at different margins, choose the most suspicious feature. For echogenic foci, choose all that apply and sum up the points. TR levels are given to nodules based on the points obtained from ultrasound assessment. The higher the TR level, the more suspicious the nodule is deemed, and the size cut off for fine needle aspiration and follow-up reduces as the TR level increases. Explanatory notes appear at the bottom of the chart. Here are some assumptions. For rim calcifications that obscure the nodule completely, choose the composition to be solid and the echogenicity to be isoechoic. If the margin cannot be determined, choose ill-defined margin. If echogenicity cannot be determined, choose isoechoic. If composition cannot be determined, then choose solid. Now we shall go to some sample images by category. This section is imaging based, but I've included it so that we can familiarize ourselves with the descriptors used in thyroid reporting. I've tried to make it succinct, so I hope you'll bear with me. The first category is composition. For cystic nodules, as you can see here, It is anechoic within with posterior acoustic enhancement. Spongiform nodules are composed predominantly of tiny cystic spaces. It is a benign finding. If there is cause for concern, such as irregular margins or suspicious echogenic foci, reconsider whether it is truly a spongiform nodule. Mixed cystic solid nodules are comprised of soft tissue and cystic spaces. Assessment of all other categories in the lexicon, such as nodule echogenicity and echogenic foci, should be based on the solid component. Solid nodules are composed entirely or nearly entirely of soft tissue with only very few cystic spaces within. Now we go to the second assessment category, which is echogenicity. So this is an example of an anechoic echogenicity without soft tissue component within. It applies to cystic or almost completely cystic nodules. A nodule is considered to be hyperechoic if its echogenicity is increased relative to the adjacent thyroid tissue. An isoechoic nodule has similar echogenicity relative to the adjacent thyroid tissue. A hypoechoic nodule is hypoechoic compared to the adjacent thyroid tissue, however, still more echogenic than the strap muscles anterior to the thyroid gland. A nodule is said to be very hypoechoic if it is more hypoechoic compared to the anterior neck muscles. Here, the anterior neck muscles are pointed out with the white arrowheads. Next, we go to the shape, which is either wider than tall or taller than wide. So taller than wide is a suspicious feature. A taller than wide nodule is defined as having a larger anteroposterior diameter, the red arrow, compared to its width, which is the blue arrow. A wider than tall nodule instead has a larger width than its anteroposterior diameter. And the next category is margin. A nodule with a smooth margin has an uninterrupted, well-defined curvilinear edge, typically forming a spherical or elliptical shape. An ill-defined nodule has borders that are difficult to distinguish from the adjacent thyroid parenchyma. Irregular nodules have an outer border that is spiculated, jagged, or with sharp angles, with or without protrusion into the adjacent parenchyma, and these protrusions may vary in size and conspicuity. A lobulated nodule may have focal rounded soft tissue protrusions that extend into the adjacent thyroid parenchyma. These may be single or multiple. And this is an example of extrathyroidal extension where the nodule clearly extends past the margin of the thyroid. So this is a feature of malignancy. And we've reached the final assessment category, which is echogenic foci. Here we choose all features that apply and sum the points. Large comet tail artifacts is a type of reverberation artifact. The deeper echoes become attenuated and are displayed as decreasing width. So they result in a triangular shape. Macro calcifications are calcifications that are large enough to result in posterior acoustic shadowing. Rim calcifications may or may not be continuous, but in some cases may be dense enough and large enough to obscure most of a nodule. In these cases, we should assume the echogenicity to be isoechoic and the composition of the nodule to be solid. Rim calcifications may or may not be continuous, but in some cases may be dense enough and large. They can have small to obscure most of a nodule, and they are given the highest points of all under this category. Echogenicity to be isoechoic. Classically, in papillary thyroid cancer, there are pseudomonas are dot-like foci of less than 1 millimeter in diameter. They can have small comet tail artifacts, and they are given the highest points of all under this category, 3 points. Classically, in papillary thyroid cancer, there are pseudomonas microcalcifications, which is what this descriptor aims to capture. Although it may be present in benign lesions, multiple studies have shown high specificity for PEF in malignant nodules. The recommended management for nodules under TI-RADS is based on the TR level. For TR1 and TR2 lesions, no follow-up or fine needle aspiration is needed. For TR3 to TR5, the size threshold for follow-up and fine needle aspiration decreases as the level of suspicion increases. If there are multiple nodules, the two with the highest ACR TI-RADS grade should be sampled rather than the two largest. Significant interval enlargement on follow-up is if there is increase of 20% and a minimum of 2 millimeters in two dimensions, or a 50% increase in volume. If the TI-RADS level increases between scans but remains below the threshold for fine needle aspiration, another interval scan in 1 year is recommended. So ultrasound scans of the thyroid should be reported based on the Thyroid Ultrasound Reporting Lexicon by ACR. Reports of the thyroid scans should include the following elements: tridimensional measurements of the right and left lobes and the anteroposterior dimension of the isthmus, an overall description of the thyroid parenchyma, formal description of up to 4 of the most suspicious nodules. So not necessarily the largest nodules, but the most suspicious based on the TR level, and recommendations for management of these nodules. As TR level increases, so too does the risk of malignancy, with TR5 lesions being malignant in up to 35% of cases. Now that we know what ACR TI-RADS is, why, and how to use it, let's round up our session with some sample sonograms of thyroid nodules and put our knowledge into practice. In the first image, this is a spongiform 0.9 cm nodule in a 59-year-old woman. As you can see, more than 50% of the nodule is comprised of small cystic spaces. So let's head on over to the ACR TI-RADS assessment chart. This is a spongiform nodule, 0 points, anechoic, wider than taller, smooth, with no echogenic foci. With a grand total of 0 points, this is a TR1 nodule. It is benign and no further follow-up or fine needle aspiration is required. Next, here is a sagittal sonogram of a colloid nodule in a 65-year-old woman. It is solid, although there are small cystic components within. And as you can see, the solid component is isoechoic to the adjacent thyroid tissue. Now, let's use the ACR TI-RADS assessment chart. So this is a solid nodule, 2 points for composition. It is isoechoic to the adjacent thyroid tissue, so it is 1 point here. And the other categories, we have 0 points. So with a total of 3 points, this is a TR3 nodule. It's mildly suspicious. For FNA, if it is more than 2.5 centimeters, and for follow-up, if it is more than 1.5 centimeters. Here, we have a mixed cystic and solid papillary cancer in a 39-year-old man. It has lobulated solid mural component with punctate echogenic foci within. The composition of this nodule is mixed solid cystic. The solid component is isoechoic. It is wider than taller, and the outer margin is smooth. However, there is punctate echogenic foci. So in total, this is 5 points, giving it a TR4 grade, which is moderately suspicious. For a lesion that is more than 1.5 centimeters, we would fine needle aspirate, and if it is more than 1 centimeter, for follow-up. In this image, we have a 2.2 centimeter carcinoma in a 61-year-old man. This lesion has lobulated margins. It is solid in composition, and it is hypoechoic to the adjacent thyroid tissue, but not more hypoechoic than the anterior neck muscles. So in the TI-RADS chart, it is 2 points for solid composition, hypoechoic, another 2 points, shape 0 points, lobulated margins, 2 points, no echogenic foci, so that's 0 points. In total, 6 points. This is a TR4 lesion. It is 2.2 centimeters in size, so we will recommend fine needle aspiration. Next, we have a sagittal sonogram of a 1.2 centimeter sized carcinoma in a 39-year-old woman. This nodule has irregular spiculated margins. It is of solid composition, very low echogenicity, and multiple punctate echogenic foci within. So here we have 2 points for solid composition, 3 points for very hypoechoic echogenicity. It is wider than taller. It has irregular margins and multiple punctate echogenic foci. So that's 10 points. And since it is more than 1 centimeter, we would recommend for fine needle aspiration. This is a 1.8 centimeter wide papillary carcinoma, bulging but not breaching the thyroid border in a 24-year-old woman. It is of solid composition. It is hypoechoic, taller than wider in shape. There are lobulated margins, especially anteriorly, and there are several punctate echogenic foci within. So it receives 2 points for being a solid nodule. It is hypoechoic, another 2 points, taller than wider, 3 points, lobulated, 2 points, and punctate echogenic foci, 3 points. So with 12 points and a size that is larger than 1 centimeter, we would recommend an FNAC. This is a sonogram of the left thyroid lobe in a 42-year-old man. We can see minute bright dots representing the speckle pattern of normal or non-malignant thyroid tissue. And this should not be misinterpreted as punctate echogenic foci. So the important thing is there is an absence of a nodule that contains these bright dots. This is an alternative TI-RADS assessment chart, which may be easier to follow as we can focus on one category at a time. For cystic or spongiform nodules, we can go ahead and give TR1 level. For mixed cystic and solid lesions, we give 1 point, and solid lesions get 2 points. These points are already added into the echogenicity category. Then we add more points for other features, and finally we give a final TR level, which will determine the management for a nodule. I understand that there was a lot of radiology and images involved, but thank you for staying with me thus far. I would like to emphasize a few key points before we conclude. So, ACR TI-RADS is a risk stratification system for thyroid nodules to guide decisions regarding fine needle aspiration and follow-up. It allows practitioners to assign points to nodules based on a standardized lexicon and structured report. Although thyroid nodules are extremely common, the proportion of malignant nodules are very low, and the decision, thus, for fine needle aspiration should be based on the presence of suspicious features rather than size alone. And with that, we have come to the end of my talk. I hope it has been beneficial, especially in helping determine whether a nodule is suspicious and which nodule requires follow-up or fine needle aspiration. Thank you, and have a nice day.
Thank you, Dr. Prasath, for that informative talk. We can see that just by scanning on ultrasound, we can derive so much information, and we can help the clinician decide on what to do next. Okay, let's check our Q&A box. We have one question here. Can TI-RADS be used in pediatric population for the thyroid nodules?
So in pediatric population, I believe this ACR TI-RADS guideline has only been validated for adults. Recently, I think about a couple of years ago, 2020, there was a study with up to, I think, 300 pediatric under 18 patients with thyroid nodules as well as FNA results. And it showed that up to 20% of the nodules that were deemed not necessary for FNA under the TI-RADS criteria were actually malignant. So probably because of a higher proportion of nodules that are malignant if they do appear in the pediatric age group. So it's not been validated. Probably they need to tweak the criteria.
Okay. The next question is, you mentioned there was vascularity features that is important. However, in the ACR TI-RADS, there's no criteria for Doppler. Can you explain why?
Yeah, that's one thing, because classically, whenever we scan for thyroid nodules, even for the thyroid parenchyma, we always turn on our Doppler to look at vascularity. But from the white paper, in the 2017 white paper, it says that it was considered, but because of a lot of inconsistent literature, it was not included as one of the criteria. However, actually, that being said, from technical point of view for MOs and people who are doing thyroid scans, sometimes it may be difficult to determine if it is a solid nodule or a nodule with probably debris within. So sometimes if you turn on the Doppler scan, it can be clearer to know whether it's solid, because if there is vascularity within, it has to be a solid lesion. So that's one of the uses of vascularity. We use it routinely when scanning thyroid lesions, but it is not part of the TI-RADS criteria.
Okay, we have another question about whether ACR TI-RADS can be used for CT.
No, it's an ultrasound assessment, but it is, let's say we see something on CT, either nuclear medicine, PET scan, a nodule in the thyroid gland, and then we want to characterize it further, we should use this criteria to decide whether we need to follow it up or to fine needle aspirate, or we can just leave it alone. Because let's say it's just a colloid nodule with only, or it's just cystic component. On CT, we might just see as a hypodense nodule. So when you follow the ACR TI-RADS criteria, it might be just TI-RADS 1 and no follow-up is required. So we need to go back to ultrasound. So that's the answer. We need to go back to ultrasound.
Yeah, I just want to add that CT-NEC for thyroid lesions is most often to assess the extent of the thyroid nodule, not to characterize the thyroid lesions. Okay. Another one is can we use it to know if it's hot or cold nodule?
No, by virtue of
we
being
don't.
hot or cold is a functional thing. So nuclear medicine, technetium, pertechnetate, or radioiodine is actually what we use to see if it's a hot or cold nodule. So the cold nodules are the ones, the non-functional ones are the ones that we are more worried about. I think hot nodules, 1% or less are malignant, whereas cold nodules up to 10% may be malignant. So yeah, that is functional, but anatomical characterization, ultrasound is still what we go to.
I think that's all we have in the Q&A chat box. I like to add that this ACR, there's many ACR characteristics. We use ACR for breast lesions, thyroid lesion, prostate lesions. Yeah, so it's a very helpful guideline that we can help our clinicians, and we hope that the clinicians understand. If not, they can always consult us to explain further. Okay, I shall pass on the next session to Prof. Jahan.
Thank you.